when you do that?
Oh, yeah.
Yeah.
Yep.
Because she is so hyperlordotic, that
Yep.
would open it up for you, and then, good.
She's super hyper.
Yeah.
Yep.
I don't think, though, it hurts to once in a while fix that fifth lumbar, though, even though she's got that hyperlordosis there.
No, I think, for example, for last month, she could tell me, she could say that, I have adjusted that L5 probably twice, maybe, counting yesterday's.
Okay.
Because I know she could get pretty symptomatic sometimes when that. So that L5, I choose L5 when I see there's everything going on well on that sacrum. But she always have a break on L5.
Yeah, I'm not surprised.
Yeah, me neither. Yeah, it's pretty.
Could I see the A to P lumbopelvic now? Is there any way you can get that muting and pin sign off the X-ray? Yeah, thank you. Oh, it's back. Did I do that? So let's talk about the listings, how they're on this film, see if they make sense. So sacral rotation, does that make sense with what L5 looks like?
Over there it says PI 0, AX 0. You can tell by visualization that she's really PI on that right side and really AS on that left side. I have adjusted that AS EX too sometimes.
On the left.
On the left, yeah, I pull it. Yeah.
So you think L5 is rotated to the left, correct?
Yep.
Okay, so that would match with the sacrum.
Yep.
Okay. So you think the wedge on 4 is on the left or it's parallel? Is that what you're thinking? That's why you did PLI?
No, it's PLI and L5, Doc, not L4.
Right, but you have to look at L4 to decide if you have a special fifth lumbar listing.
True. Okay.
So when you say PLI, do you mean PLI or do you mean PLI-M?
PLI-M, yeah.
Okay.
She does have that left mild scoliotic lumbars.
Recently, Marcos adjusted me as a T-L.
The sacrum?
Yeah.
I'm sorry, what?
That recently Marcos did on me a P-L. In the film it says P-R, but he did a P-L. Correct me if I'm wrong, Marcos.
I did a PL at like a PL, but that translates as a P-R. So I was on the yeah. Sorry for not being more clear about that.
So when you palpate her, Carlos, are you finding the swelling and the soreness in the SI joint, or are you feeling it at more midline?
On the sacrum.
Right on the sacrum.
When I choose to adjust the iliums, it's because she's not moving well on that SI joint, specifically, on that left side.
See, I'm looking at L5 there, and I'm wondering if it isn't PLS-M. might make sense why some of the pain is on that left side, because the wedge is on the left side.
The wedge is on the left side.
Looks like there might be a small wedge on the left side of L5. So instead of a PLI, it may be a PLS, and then you'd have to fix it PLS-M. So in other words, you would just change your torque.
I could try and see how she does with that adjustment like that.
I mean, the next time you think it's L5, really check that really close with your palpation to see if there's a wedge on the left side of 5. Does that make sense?
Yeah, it makes sense, Doc. I can tell from my cell phone, which that's what I'm looking at.
Do you ever check her leg length?
Probably just twice.
Yeah, you might want to see what that looks like when it's like if you're trying to figure out the difference between the fifth lumbar, the ilium, and the sacrum. Yeah.
She should have that right leg short, but I don't. Yeah, I have to check that.
That measured efficiencies measurements looks
huge.
I don't think it's that much. Do you? I don't think it's 7 millimeters. That looks like way too. Sounds and looks like it's not that much, but that's why I was asking you if you've checked it.
No. I mean, I can't remember what was when I checked. I can't remember.
I don't think you ever checked the legs.
No.
Okay. Well, it looks like you're on the right track. Low back there.
She has gotten better. She was getting diversified care. When I got to the clinic, she was passed down to me, and since then she has been just getting better and better and better. Sometimes she just occasionally you can tell, like you just do stuff and just.
Sometimes it can go both ways, or I do get better and then I get worse. Like sometimes I can just be there and I walk into the room and no adjustment has been made to me, but then the next day is like, yeah, I need an adjustment. And sometimes he just tries to do one thing at a time and it's not working, but sometimes it works.
One time
being a Palmer student, sitting all day doesn't help, right?
Yeah.
Yep.
Okay, let's see if we can figure out.
Oh yeah, definitely. You could be stressed too. Yeah.
Okay, how about your neck and upper back? Do you have any issues with that?
I recently had a T2 that was really locked. I don't know where that came. Well, I actually do know where that came from. I got a bad adjustment, not by Carlos, but someone else. And
wait. So that's another thing.
That wasn't from you.
I'm not the only one that have been adjusting you. You know.
Yeah, that's true.
So yeah.
Yeah, that's part of the problem too, right?
That's part of the problem. I think that's the main problem here. But I'm not fighting that because it's impossible not being adjusted by other students, you know.
Right, I get it. Yeah.
Yeah, so I got my T2, I think it was. I don't know what was the listing, but Marcos got it, and it was amazing. And yesterday I got, I think, T1.
T1 was.
And then sometimes when I get a really bad headache, I need to get my occiput adjusted because it gets really locked to the right.
So do you see the lines on the cervicals? See how they're not crossing, they're feathering out. If we can trust them, it's hard to tell, but that would be telling you that the problem, you want to stay lower, like where you're at. So, can we see the A to P then on the upper, please?
that looking is wrong. I don't have an ASLA.
Yeah, see, she doesn't have an ASLA. Her issue in the atlas is on the right side.
Yeah, so look how she's stacking. So those two vertebrae that are listed there are probably pretty good listings. I mean, as far as the ones that you want to list. Doesn't mean that's what you're going to fix, but that's the ones you want to list.
Just
Okay.
this looks normal, or do you think there's something wrong with the vertebrae per se?
Well, there's misalignment, but that doesn't mean, you adjust what you find on the patient, but it gives us a good idea, based on that lateral. I think staying lower in your upper thoracic area is the better thing to do.
They would be low back and upper thoracics.
Yeah. I mean, I get the idea of once in a while that you might have to go up top and fix something for a temporary headache, especially as a Palmer student. But long term, I think you want to stay lower where they were, upper thoracic.
Yep.
You have a shoulder problem too, right, Kay?
Yeah, it's my left shoulder.
Tell us about your left shoulder.
Huh?
Tell us about that.
I had an injury while I was working out. My elbow got caught up in some metal bars, and when I received the impact, I thought it was my elbow who actually received the impact, but the effect was on the shoulder. So my shoulder was out of place, and I was doing okay until slowly started to lose its mobility. I couldn't even raise it up. And then I went to a chiro. He did to me activator because he couldn't even do a manual adjustment on me. Then after like 4 or 5 visits, he then made a manual adjustment on me. Then I came here and I started to get hurt. And I was diagnosed with, I think it was bicipital tendonitis or something like that. I got an x-ray for that. I never saw those because those were made here in the clinic. I got them because literally I begged at the student to get me some x-rays because nothing was helping. She was doing laser and nothing was helping. And then she diagnosed me with bicipital tendonitis. It's helped with the rehab exercises, but since then it's been clacking and sounding and yeah.
So it's the pain is in the front of the shoulder?
Yeah. And I have a wing scapula on the right too.
So yeah, that makes sense. So have you had Carlos adjust your shoulder or look at it, palpate it?
She hasn't told me that she's symptomatic, so I don't touch asymptomatic extremities.
Well, sometimes it hurts, but I don't tell you anything.
Good patient, yeah.
Yeah, so you might want to check that and see what visually what it looks like, if it's an AI or just what it is, and see if you might be able to help that.
She was actually getting adjusted with this weird thing that they put when the humerus goes anterior, it wasn't good because she needed an posterior adjustment, not an anterior one.
Okay.
So it was actually making sound, but it wasn't. That's the case about making sound or.
But you can make sound in the wrong direction, right?
Yeah.
It wasn't helping me.
Yeah. The extremities, if you're pushing them in the right direction, they usually get better pretty quickly, unless you've got a real big structural problem, like something torn or super arthritic.
And now recently,
I think she got some laxity on those ligaments. That's why too.
probably. And the new thing right now is I have extremities issues, my wrist and one of my ankles. I don't know why that's happening, but I have problems with them now.
Oh, I remember I looked at your wrist between classes the other day.
Yeah, I think that hold in for like 2 days, and then it went back again.
Okay. Some of that might be because maybe you're injuring yourself while you're learning how to adjust your.
Yep, that's what I told her, right?
Yeah.
Yep. She's pressing too much. I mean, we all do that. We do it when we are learning setups. But I'm telling her that to relax when she's doing setups.
Okay. Yeah.
Yeah.
All right. Yeah. Anything else you want to talk about? What you see on Kay's films or what she said?
You ready for the next one? We have Kyle. Good old Kyle.
All right, Kyle.
No one has any other questions?
Hey, Doc.
Right.
How's it going?
Good. How are you?
I'm great.
Alrighty, so this is Brittany and Kyle working on this together. We don't have any stitched pictures. It's only individual. So Kyle, do you want to give your history first, and then we'll go from there?
Yeah. I've had low back pain since I think I was like 15 or 16. Kind of like trauma related because I snowboard a lot, and so I land on my back on the snow, on rails, on trees all the time. So I've never broken anything, thankfully. But I've had just diversified care up until coming to Palmer, and then I started seeing Brittany at Tolan Clinic. And really the pain is just kind of like a dull pain around my L5, L4 area. And just getting adjusted from Brittany and sometimes Marcos has really helped it out a lot. The only thing that makes it worse is like really going into an extension. So like deadlifts or squats, I really don't like to do anymore just because that usually flares it up pretty bad. And so that's just what I've kind of noticed.
So it hurts on extension when you have weight on your shoulder, or just
extension in general. Yeah, even if I just extend back in my chair, it kind of hurts a little bit just sitting here. But that's why I don't like to do any kind of weights in extension because it makes it way worse.
Okay. I'm looking at the lateral there, and looks like L5 is slightly posterior inferior. But I also see that sacral segment between 1 and 2 is open in the back a little bit. I don't know if that's ever been adjusted, but that might be some of your extension problem right there.
Yeah, at the beginning we kind of focused on, and Brittany will probably know better all the things that she's adjusted, but at the beginning we just kind of focused on L5, and it didn't really seem to go anywhere. And then we've been, I think we've been doing like S2, S1, I think in there, and that's gotten a little bit better results.
Yeah, we've done, so like you said, we did L5 in the beginning, and then recently we've been trying to do S2. We've also done ilium, but we haven't quite figured him out yet.
It always comes back. Nothing really makes it like go permanently away.
Yeah, and his low back is like super tight. Like no matter what, if he's sitting up, if he's laying on his side, it's like he's just super tight down there. And he has edema at that L5 starting at L5 into his sacrum.
And it seems like he's really hyperlordotic when he's seated or Brittany tries to adjust him.
Yeah.
But looking at the film, it doesn't look like that.
Yeah.
It just seems like when he relaxes, everything just goes so anterior.
Mm-hmm.
Well, I'm looking too. What you might have to do to help the stiffness in his lower back, you might have to go up to maybe L2.
Yesterday, one on the knee chest, and I think someone else has also done his L1 T12 area as well, and it felt better, but it didn't last. Like I think his muscles relaxed like right after that adjustment, but then the next day he said it was just back.
Yeah, it looks like to me, I haven't seen the A to P yet, but at least on the lateral, I would be thinking sacral tubercle S2 and then either L2 or L3.
Doc, what do you see like down here? Is there anything right here you see? Or not really?
There's letters in front of it, I can't see.
Oh, really?
It says presentation, Marcos. It's got your name on there.
Sorry, is that better?
There you go. Yeah.
So like right in here, I didn't know, it's just something that we were looking at. But
Yeah, what is that, the first or the last sacral segment there?
1, 2, 3, 4. Yeah, 4, and then that's 5.
Yeah, well, you might check it.
All right, you might need a coccyx.
Yeah. I don't know about that.
Internal.
I don't know if Brittany and I are that close.
At least it's by Brittany.
I'd rather Marcos do it.
Right, Kyle.
No offense, Brittany.
Yeah.
I guess just buy me dinner first. I don't know.
Everybody has their DRE OSCE this week, so we're all practiced up, Kyle.
Yeah, I'm ready. I already had it. I got 100 on. Let's go.
Oh, no.
It's it's weird. Sometimes those little dinky things that you see there, that could be just like the last little thing you need to do to clear stuff up or to figure out, that general stiffness that doesn't just seem to go away. Sometimes it could just be these little small things that you see.
Yeah, the thing that that caught my eye was just how drastic this changes right at that segment. Just it's going this way, then a straight beeline, pretty much straight there. I don't know if that's normal anatomy or what, but I just thought it was something to.
Well, you'll find out by palpating it and stressing it a little bit.
Yeah.
Because if it's clinical, it'll tell you.
Mm-hmm.
You just need Kyle's permission to be down there.
Oh, man. Might have to get a couple drinks in first before I feel comfortable.
Did you want to see the A to P, Doc?
Yeah, I can see the A to P. Uh-oh, he swallowed something there. Can you enlarge that a little bit?
Which part? The L5?
Yeah, just the whole image there a little bit. There you go. Thank you.
Yep.
Can you go a little bigger?
Yep.
That's good. Thanks.
This is a really good picture.
Yeah,
Yeah, it's downloaded from the disc. So.
How are you fixing 5? What's your listing?
I honestly don't remember what we did. We haven't done L5. And
Yeah, we haven't done L5 since Toll.
Yeah.
Oh, okay. All right.
I can go to clinic today to look at his note for this. I should have.
Okay. Does it set hard or easy when you try it?
Oh no, it doesn't go anywhere at all.
It
Are you
doesn't
trying?
budge.
Are you trying to push it or pull it?
I've tried everything. Push,
Push, pull, knee, chest,
Yeah.
high, low, hitting it with a shovel.
He's got sagittal facets, so it should be all right.
I mean, it could definitely be a knee problem, but I seem to get somewhere with other patients, and then Kyle comes in, and I'm like, oh boy.
He's your challenge, huh?
Oh, to say the least.
Does the sacral rotation match the lumbar rotation?
Do you think it's a PR? Lumbar? I mean, sacrum?
Well, L5 looks PL.
Yeah.
At least the pedicles look PL.
And the facet here, right? Doesn't it look like you see a much better view?
I think there's malformation in those facets.
Okay.
And then the SI joint, like the left looks more swollen.
No, I wouldn't. I don't know why I would say that.
Are you thinking of PLI? Spinous?
Because 4 is definitely PL.
Yeah.
So maybe
Yeah, PLI. And
PLS possibly.
I do think one of the times I adjusted his L5, I don't think I did it with a wedge. So I remember just saying that I don't think I feel a wedge, and that I was just doing like a PL.
And that'd be fine. You're not. I mean, you're not going to do anything wrong by being just PL.
I mean, it didn't go, but I didn't know if it was because I didn't have the torque for the wedge.
Well, it's not a big wedge, so, and it's not super posterior either.
Right.
So that's why I'm thinking it might be some of these other things. It might be an upper lumbar, or it could be, down in the lower sacral segment.
What do you see that as? I did a PR yesterday.
Say that again.
What do you see the S2 rotated as? Like, is it?
S2?
Yeah. I did a PR yesterday on it.
Can you get your name off of that, Marcos?
is that better?
Yeah. Just go up just a little bit more so I can see the top of the sacrum.
Is that okay?
Yeah. I think on that S2 tubercle, I'd be on the right side of it.
Okay, that's what I did yesterday. I tried it on the knee chest. I didn't really feel anything, but I felt like when I palpated him, it felt better.
You might try pushing it on the bench.
Oh, I have.
Okay. Have you tried prone with the bolster?
No, we don't have nice things like that. And
Okay. Do they have any kind of pillow that you could put under it?
just the pelvic bench pillows that they have there.
Oh, yeah, that's not so good.
And I don't even have like a swing away. Yesterday was the first day I got rebellious and walked down to get the knee chest and bring it to our side. So.
All right. So is it point tenderness on it?
Yeah, it was yesterday.
Okay. And how does it feel today, Kyle?
It feels a little bit better.
Okay.
Like I could tell, like kind of right after she adjusted it, I could extend back a little bit better.
Okay. Well, to me, that sounds like you're on the right track. And some things, when you start, a lot of patients, when you start work with them, some people are just, they're not going to make a lot of noise or any kind of audible, and then then it might be like the fourth or sixth or 10th visit or whatever it is, all of a sudden it'll just explode. just because it took a while for it to get ready enough to move enough to really make a difference. So don't get discouraged if you don't get an audible right away.
I'm waiting for that. Been long enough.
When those are really ready, they just almost like you touch them and then you almost have to catch up with them on the adjustment. Yeah. But I think you're on the right track there.
So do you think kind of like leaving that L5 alone and more doing that sacrum? Yesterday the break was very obvious that it was lower on the sacrum. But also break isn't really at L2, L3. It's definitely at more T12, L1. So I don't know, would I go check down to L3 even though there was no break there, or?
No, don't let the x-ray fully tell you where to adjust. I mean, you want to go by what your scope's telling you.
Right.
But yeah, L5 almost looks like it's one of those L5s that if you got too aggressive with it, you would actually make him worse.
Right.
Yeah,
That's why. Yeah.
It looks pretty parallel, I thought, or like pretty even. Didn't really look posterior.
So when you see a disc like that, you want to be smart with it and look at other things around it if you can.
Okay. That's definitely good to know.
Do you think this could be an ilium problem possibly, or probably not?
Well, anything's possible, but we got some good evidence on those sacral segments, so I think I'd hang with those for a while. Or if, once in a while want to go up to that upper lumbar, that'd be all right too.
Okay.
So did you do an upper lumbar yesterday, Brittany?
Yeah, I did L1 yesterday too.
So Doc, what do you normally think when you see someone and their low back is so fired up? Like just hypertonic to where they're having a tough time relaxing to a point where you even feel like anything. So I feel like that's Brittany's biggest problem with it is he's so like tight in that area. No matter what position she puts him in side posture or knee chest.
Yeah, so I always had the idea that I'm not going to fight with the patient because that just makes the patient tighter. So I try to find ways to get the patient in the most relaxed position possible, and maybe it's high-low prone with the bolster, as opposed to if you think the side posture, you just can't get him relaxed enough to move it. To me, it's always better to get him more relaxed and be lighter than just try to start forcing stuff and pounding on him.
Mm-hmm.
It's kind of like, I think I've used this analogy before. It's kind of like sometimes you got to think about it as almost like a frozen pound of ground beef. You got to thaw it out a little bit before you can mold it into what you want it to be. So.
Okay, that's good to know. Thank you.
More so with people my age, but certainly young people too can be pretty tight, pretty stiff. You just gotta don't be in a big hurry. You don't have to hit a home run every time. It's about base hits.
And he's also super hyperkyphotic too. If you look at his lateral here, I think this could have something to do with it. Something in here.
Yeah, and certainly his neck too. So yeah, he's almost got like I can't tell which one it is yet, but it looks like maybe T7. He's got a little bit of a compression fracture there.
Yeah, we were gonna ask you about that.
Either that or maybe he had that one and the one below it, like maybe 6 and 7.
Mm-hmm. And here,
maybe he's got the end plates look a little rough, so maybe he's got Sherman's.
That's what I said to him. I asked him if he's ever heard that, and he said that he has not. But Kyle, have you ever been like looked at for that?
Oh, I've never been X-rayed before I went to Dr. White's. My chiropractor back home just does diversified, so I've never had an X-ray.
So can you magnify that, Carlos or Marcos? Sorry. Yeah. Do you see the wedged vertebrae there?
Mm-hmm.
Put your yeah. So that one is that T6, the one you got your arrow on.
Let me count. Hold on. There's a. I have it on my iPad too here. So that is. So. 12. Yes, that's 6.
Yeah. So. And then even 7 is compressed in the front. So what are you guys adjusting in there?
I think it's lower. I didn't do anything there yesterday.
Look at T9. Look at even T9 looks like it's wedged there.
I think that is where we are.
Yeah.
Like a T9 tape. I don't remember that either.
So can we see the A to P then and see where the stacking is on the A to P? 'Cause can you enlarge that just a little bit?
Where, right in the middle, kind of? Right here?
Yeah.
Okay.
I just want to kind of see the rotation of that T8, T9. Now I'll go down a little bit. Okay, right now I think, is that T9 right there?
12.
But you got your arrow on?
10.
That's 10?
Yep.
12, okay. Yeah, so see how right about there is where, see where the stacking happens between that 11 and 10?
Mm-hmm.
And then they go straight up there.
Yeah,
Right.
on that left side, so it's tipping to the right, but and there, look how much rotation is on those.
Yeah.
PL.
Mm-hmm.
So you think it's just something with the X-ray machine? Why these are so different colored?
Yeah, you know, I'm seeing a picture of a picture, so
Well, this one is from the disc.
Yeah.
So this one is straight from the X-ray film, and this is the result of it.
it looks like you have overlying anatomy too.
Uh-huh. Yeah, right there.
Because you can see how the shadow of it changes from, you know,
Bolt to one side.
from 9 all the way down to 12 there.
Mm-hmm.
Yeah.
That looks like overlapping anatomy.
Okay.
Does he have very large?
Let's see what the lateral looks like on those particular vertebrae.
Dr. Meisel, do you think his pedicles are really big?
Do I think his pedicles are big? Well,
They look like they're really very easy to tell. It's almost like someone made it like that so you could learn the rotation like super easily.
well, you know, when you
I
magnify
did it just for you, Brittany.
Kyle's got big pedicles.
Okay, so can you magnify that lateral right in there?
So we said it was what, 10, 11, 12 that was like that?
Like
So
9, 10, 11, 12. Yeah. See, I don't see anything weird on this on the side view, lateral view.
Okay.
But I do see, you know, those end plates look rough. The Schmerl's node area looks a little deformed, especially on that T6, T5, T7. So I think he may have had some Shermans going on.
Mhm.
You're in great company, Kyle. I have that too.
Oh, sweet.
Then his neck is just straight as.
Yeah, my neck
Let's
is
see
very
his
straight.
neck. Let's see his neck.
Almost to reverse curve. Maybe
Yeah.
beginning to be.
And that's a pretty good picture too, because look at the hard palate. See how that's pretty level to the horizon?
Mhm.
So that's what you always want to try to look at to trust if the lateral curve is truly, what we think it is. If that hard palate is angled downward, from the nose down, then that would be that would create a kyphosis. And then if the hard palate, the front of it is superior, then that's going to give you a false sense of a lordosis. So that looks pretty good.
Right.
Can you zoom in just a little bit?
Yeah, where you in the middle?
Yeah. That's good. Yeah, I mean, I can't see C7 because the letters are in the way, but yeah, I don't think you'd want to go any higher than 7.
Do you think this looks posterior? Right there?
Yeah.
Even
But
inferior?
I can't see T1 though, but that one it looks like that might be where the kink is right there.
Mhm. You want the A to P?
Yeah. Yeah, see how it takes off there?
Mm-hmm. Right there.
Yeah. So how would you listen? Have you fixed his C7?
I have not ever really gotten a break there.
Okay. So you're just staying in that mid dorsal?
Yeah, the low back is my main thing that I've been trying to figure out with him. And then lower mid dorsals I do, yeah.
Well, yeah, if you're not finding anything in that lower cervical, leave it alone and stay in that mid back there then.
Mhm.
Because that's definitely going to be a long-term area for Kyle, just like it is for me.
Yeah.
Kyle, did you play any contact sports in high school?
Nope, just
college?
snowboarding. So
Okay.
my
Well, that's
back
plenty.
contacting the ice.
Yeah, that's plenty, right?
Yeah.
Yeah, good case. I think the lower back can be figured out. You just need a little bit of time with it, and then Kyle, don't let anybody who's not part of our Gonstead group touch that L5.
Yeah. I don't let anybody that's not gone to the group adjust me at all. It hurts too bad.
Yeah. You learn that early. I don't know why more people don't understand that, but
Doc, could this be how you see the jaw?
he's got some deformity there, doesn't he?
Yeah, with that jaw.
Does he have any symptomatology though?
I had TMJ a little bit, just like a little bit of pain and a little bit of grinding Q2, but it just kind of went away. The pain did. It still kind of grinds a little bit, and it gets tight sometimes, but since it doesn't hurt, I don't really mess around with it.
Yeah, it looks like it could use some work, but if it's not symptomatic, you want to leave it alone.
Yeah, I've hit that a couple of times. So
Oh yeah, your side of your face hit the ground.
there's one time I hit it on the snow while my mouth was open, so I think that's where it started.
Right. So your mouth was a scoop shovel? Is that?
Yes, I ate a lot of snow. It was white though; it wasn't yellow, so we're good.
That's good.
Cool. Thank you, Kyle.
Yeah, thanks, guys.
Yeah, thanks, Kyle.
We have a bunch of people that could possibly go, so does anyone want to go next, specifically?
I can go next.
Who's that, Patrick?
Patrick, yep.
All right. Do you want to just go through your how you're feeling and what your symptoms are and stuff? Or what people have been doing?
So lately I've actually been pretty good, but back when these were taken, I was having a lot of like mid back pain and like upper dorsals pain, which is what I had been getting adjusted a lot, like T8, T9 mostly, and then usually like T1 through 3 is where stuff will come up. I usually have L4 is usually pretty tender to the touch, but I don't really have a break there very often, even though it's always pretty painful.
Can you zoom in on that? L4, L5?
It's a healthy L5 disc.
It's a little posterior. 4 is posterior inferior. It looks like it also 4's got a lot of rotation on it because you can see that back side. Yeah, right in there. See how that looks rotated there?
Is that an avulsion fracture even a little bit right there? Or no?
You might just be seeing a shadow there.
Okay. Would you say this is a swollen disc or a healthy disc?
Well, if he's lacking trauma, I would think it's his normal healthy disc. But you know, look at the back of the sacrum compared to the back of L5. There's some posterior inferiority there.
Mm-hmm.
He's got a sacral tubercle there too, between 1 and 2.
It's very open.
Yeah. Anything lower than that? Yeah, maybe even that one, right? Between 3 and 2. Who's taking care of you, Patrick?
Kind of a mix of people. Alex, mostly, and Mac. Mac, at this time, Mac was adjusting me kind of regularly.
Do you know what he was adjusting?
Mostly like T8, T9, usually.
Okay. So you really don't have any lower back complaints?
Not really. I don't really ever have low back pain. But like I said, when people will palpate me, my L4 usually is kind of tender when they palpate it. And sometimes the sacrum is tender to the touch as well.
Sacrum, like how low?
Like S2 usually.
Yeah, okay. I would check even S3, and then can we see the A to P?
I really haven't had very many sacrum adjustments though.
Yeah.
Kind of looks like that L5 spinous process kind of malformed, right?
Yeah.
Almost like a bifida.
Yeah, so you can't trust where the spinous is sitting there, can you?
You say a PL sacrum? So a PR5.
So I'm trying to look, without the lines on sacral rotation, but I'm also looking to try to see the facets of 5 and then L4. What does L4 look like to you guys?
I think it looks PR to me.
Yeah, it looks PR because of the pedicles. Yeah, you can back out a little bit, see what L3, yeah. what L3 looks like. See, everything above 5 looks like PR, doesn't it?
Yeah, I'm pretty sure it looks that way all the way up too. If you look at my upper dorsals, they all look PR.
So that starts making you think about the sacrum.
Yeah. Do you want to see the dorsals? Oh, yeah.
Yeah, look at that.
All PR.
So you kind of start thinking about the sacrum is influencing, because of it's the base, it's influencing everything up above it. So does it look like it's a P-R sacrum? It would have to be, right? To do that to the spine?
Wouldn't it be a PL? To make PRs up?
The body side of the sacrum is rotated posterior on the right.
You think? Oh, I was asking. I thought a P-L sacrum would make PRs all the way up.
I thought the same as Marcos.
Oh, okay, I see what you're saying, yeah. P-L sacrum causing PR above it, yeah. You're right, yeah.
So, unfortunately, I didn't get screenshots with the measurements on it, but when I did measure, I had a little bit of IN, a little bit of EX, not really any PI or AS, and the sacrum was, if I measured it correctly, it wasn't really that rotated. I don't remember the exact number, but it was
Can you go down by the symphysis pubis there and then magnify that area there? Okay, so the gluteal fold looks like it's a little off. See how it's not going through the symphysis pubis? So you could have a little bit of malpositioning going on there. Okay, now back out again.
And wouldn't that make the PL sacrum look not as PL because it's on the right? That gluteal fold? So if we put the gluteal fold more centered, it would make it look more PL? Maybe.
Possibly. I'd hate to guess that.
Yeah.
But something's happening in that sacrum to make that, the rest of the spine up above it, all rotate the same direction. How about your his prone leg check?
Prone leg check, I know people always get whatever a positive deer field on the right is. So I think that's, what is that, short that goes long? Yeah, so my right is usually short, and then when you lift the legs, it goes long.
Okay. And it looks like the femur head is low on the right.
Mm-hmm.
What do you think about in the acetabulum? In both of them, there's kind of like kind of more medial on the superior side of the acetabulum. Each of them have like that.
That rim defect. Go ahead and magnify it. Back out just a little. Yeah, so it's on both sides, so it's probably just a congenital. I won't say defect, but like an anomaly. Do you ever have any trauma to your? Do you have any trauma to your hips?
Well, I ran cross country in high school, and I ran a lot of mileage, like very high mileage. So I had like stress fractures in my tibia. So I'm sure if I had the stress fracture in the tibia, I could have had stuff elsewhere as well.
The joint space though looks nice and thick. I don't think I'd worry about it.
Doc, what joint space were you talking about there?
The acetabulum.
Okay.
On both sides.
Okay.
And it looks like the head is sitting up in there pretty normal. When you look at that, I forget what the name of the line is, where you go from the neck of the femur immediately then into the top border of the obturator. What's that line?
Klein's, or I don't know if it's Klein's or something else.
Yeah. But see, you can see the positioning issue possibly between, if you look at the lesser trochanter on the right and the distance that is to the ischium on that side, and then you go to the other side and you look at the lesser trochanter and that distance.
Mm-hmm.
So there might be a little positioning problem there. But I think you can bet that sacrum is the key to what's going on up above it.
Yeah, for sure. Did you want to see the dorsals, Doc?
Sure. Go ahead and make that bigger.
Right in here.
Yeah.
Okay.
Yeah, so he's got some wedging, not near as bad as Kyle's, but a little bit in there.
Would you say this is a pretty big culprit for how?
Yeah, that's 7. So you'd probably want to fix the one below it, 8 or 9.
Uh-huh. Yeah,
That's what I have been getting done the most consistently for the last probably about 6 months is 8 and 9.
Yeah, that makes sense. And then if you go to the A to P, let's see where the stacking is.
So that's 12, 11, 10.
Yeah, look at that wedge right there. It all tips left. So are they fixing it like a PR?
I believe so. Is Paul on this call right now, actually? Or is Paul not here?
He's probably driving home from.
Because I know Paul adjusted it one time, and he told me he did something kind of like, he said it was advanced, that instead of going I to S, you went S to I on something.
Yeah, I remember that.
There he is.
No, it's me. Brianna.
Oh, what's up, Brianna? He was in that area, too.
Yeah, I can't remember which one it was. Wasn't there at...
It was at T8, but I don't remember exactly what he did.
You might have just been trying to close that posterior wedge down. I think that's
Yeah, that's all he
did. That's what I was thinking. But like from T8.
Mm-hmm.
How's his cervicals look?
Do you want the lateral or the AFP?
Lateral first. Okay, zoom in just a little. Okay, so we can see his hard palate. His hard palate looks pretty level. So yeah, he's got a loss of lordosis with.
Not too proud of that neck there.
I don't think anyone is at this point.
6 looks really inferior. How does 7 look? Can you raise it up a little bit? Yeah, so, 7 looks posterior inferior too, so I don't know when you scope him. You got to be careful to decide, where your reading actually is around that C6 spinous. Because it's almost right on top of the C7 spinous, that IVF on 6. So what have you guys been adjusting? Have you even been in his neck?
Mostly like T1 actually, more than
T1?
yeah. I haven't really. So I don't know if you remember this, but before these were taken, I was getting like a lot of diversified care just from like trading adjustments with classmates like in Toll and CLM, and I would get headaches a lot from basically any cervical adjustment. So we kind of strayed away from cervical adjusting and we started doing like T1, 2 mostly.
So when they were giving you headaches, what do you know? Did they even know what segment they were on?
Usually like 5 or 6 maybe.
Yeah, well, 5 definitely would be a mistake. You could make it.
I think it was mostly 5 and 6.
Yeah, and it was all supine.
Yeah, supine and also like prone diversified. That's one like where you turn the patient's prone, you turn their head sideways.
Okay, so let's kind of talk about that. Can you go to the A to P, Marcos?
Mhm.
On his neck. Okay, so let's just talk about that. I have no idea what they did to him, but let's see we can figure out why it made him worse. So everything's rotation-wise looks like a what?
PR.
Here. Okay, so Patrick, do you remember when you were lying supine, which way they twisted your neck?
They usually turn my head right.
And where was their contact?
So they do a body contact on the left, but they turn my head right.
Okay.
There's like the lamp head.
Yeah, exactly.
And then they
Right. So if you were going to adjust, let's say his C7 or C6 Gonstead, what listing would you use?
Seven looks PRS.
Mm-hmm. Doc, would you do like on T1 potentially like a PR-L?
I'd stay PRS on T1 or. See, I think that's the problem. They're trying to pull things around and they need to stay on that right side.
What about that, like towards the bottom of the screen right now? I think that's T2.
I could get the. Hold on, I'll get this.
Yeah, doesn't T2 look like extremely PR?
Yeah.
Yeah, you're PR all the way down. You're PR from the bottom. Yeah, that's why we were talking about the sacrum.
But you wouldn't be concerned with that T2 right now, the way that looks.
Well, because I'm going to use the lateral to really help me decide which one I'm going to be more concerned
Yeah, I
about.
think those upper dorsals, they didn't come out good in the lateral, if I remember correctly.
They're a little light, aren't they?
Yeah, they got kind of burned out.
Actually, no, that's not. That's the opposite of burned out.
Not burned out, yeah, they weren't exposed enough.
They're underexposed, yeah.
Yeah.
Yeah,
This
see,
one's better than the other one. But still, you can't see much.
yeah, I don't think there's any problem with staying down in T1, T2, C7. As bad as 6 looks like on the lateral C6, when they were twisting your neck, they were on the wrong side for what you need, and they're probably too high. And I'm sure they had findings there. I'm sure they had taut and tender muscles and. Where did you get the headache?
Usually like frontal and on top.
Yeah.
Yeah, it'd be interesting to see what happens if Pat got his CL taken. How much else that would clear everything else up.
Right. Who's taking care of you mostly now, Alex?
Yep, I think she just joined the call actually.
So you'll have to fill her in.
I will. Can we?
Wait, were you guys talking about me?
We were.
Can we
Sorry.
go to the AP cervical again? Because I also have all the TMJ issues, and I was wondering if you could. I don't know if you'd be able to catch anything here with that.
It looks deviated to the left.
Yeah. Is the pain on the right?
Mostly, yeah, mostly the right. Brianna, I'm sure you remember Paul. Paul used to use me as a lab rat with that one for a while.
For sure. Rightfully so, Patrick.
After last night, he was I think he wants to go back at it again.
Yeah, he's pretty pumped up about TMJ.
I'll have to go see him this weekend.
Yeah, good case. So it'd be interesting to see what happens with how you do working on that sacrum.
Mm-hmm. For sure. All right, who wants to go next?
Thanks, Doc.
You're welcome.
Can I go?
No.
Who's that?
Michelle, Johnny.
All right, we'll go Steven, Michelle, then Johnny. Because Steven. We got you.
Which Stephen is this?
S3.
Little Steven.
All right.
History, yeah.
With a big heart.
That's right.
Steve, you want to go give a little background?
So, I mean, I didn't really have any, like, pain or anything. But I've been wrestling and doing taekwondo and skateboarding, so just, like, regular tightness. I mean, the only symptom I maybe used to get was, like, when I would do, like, laying leg curl or squats or deadlifts, I would get, like, tightness in my lower back, like the erectors. Like, maybe sometimes it would be one side more than the other. So Brittany's been adjusting me with the sacrum. She's been doing a base posterior, and I didn't really notice it because I didn't know that it was like kind of like something we would be looking for. But my frequency of going to the bathroom has slowed down, and it was before it was like almost like as soon as I would eat, I'd be going. Now it's like once a day, and I think that. And it's kind of started around the time that she's been doing that, the base posterior. Like it normalized now.
Makes sense, right?
He also had knee pain, right, Steven?
Oh yeah, that's right. I had it was like left knee pain. I forget if it was on the inside or the outside, but it was like for a couple weeks. And I was thinking that it might be like, oh, I tore my ACL or something, or meniscus or one of those, because I was doing jiu-jitsu at the time. But then Dr. Pam found a break at like L1. Then we got x-rays. Brittany did my base posterior. It fixed the L1, and within like 5 or 10 minutes, the knee pain was gone. So I haven't had knee pain since.
So his base posterior looks better in these x-rays than it did from the ones from Dr. Pam. The ones at Dr. Pam, it was like very, very obvious that it was base posterior.
Okay. And does he have 6 lumbars?
Yeah. And I have
Things are pretty crowded down there.
Yeah. And I've showed this actually to a few. I think there's like 2 or 3 other doctors. I think it was Dr. Barger, Steve Barger, and Vin. I think Dr. Vin, who's up in Jacksonville. They said that they would do it like a spondy. So, and it's always confused me.
All right, so go ahead and Marcus, can you magnify that joint?
Yep.
Okay, so typical presentation of a base posterior sacrum, the disc is going to be open in the back, and that posterior edge of that sacrum is going to be posterior compared to the back of the body of L5. And then look at L4. With the base posterior, L4 is really compensating where it's open in the front and narrower in the back. So when you set that first sacral segment as a base posterior, it's I to S, P to A. A spondy, you'd set it S to I, P to A. So for me, I would think that would make it worse to set it like a spondy. The only other thing you could do too to rule it out would be to take obliques. Let's see if there's a pars defect there.
Does he have?
Is that 6 lumbars or is that 5 lumbars?
He has 6.
Okay, cool. Thanks.
Yeah, Steven, didn't you get a spondy type of an adjustment and that made things feel a little bit worse as compared to when you got your base posterior adjustment?
It didn't really. So the only difference that I noticed, so I was fine that day. The next day in the morning, I felt like my neck was a little like tight, just the musculature around the neck. But then, like it was just in the morning. By midday, I was back to like normal. So it didn't really.
No, I'm talking about the one a little bit longer ago, not the more recent one. When you had more of a presentation of base posterior, didn't you have a spondy type done to you, and then it made?
Yeah, that's what I'm talking about. It's that I got like tight muscles in the neck, like I could feel it, like it wasn't like tense, like it wasn't like I was just sitting for too long. It was like I woke up and everything was just locked up, but then it kind of relaxed afterwards. But it didn't really. I didn't have any pain or anything from it. That was the only thing that I kind of noticed.
You got lucky, because I think if you kept doing it that way, I think you're gonna make it worse.
And then pushing it like I to S in that manner, would that like make just the angle of that L6 like make it more? I think like increase it more. I guess is that.
Not if it's a base posterior, but let's look at the sacrum lower than that segment.
Coccyx. Full posterior.
I can't see it because of the lettering there. Okay. Can you lower the film just a little bit? A little bit more, bless you.
Sorry.
Okay. Yeah, so I would be suspicious of that tubercle between S2 and S3, even S1, S2. But yeah, that one right there. That might be part of what's going on up at L5, S1 too.
I think Dr. Barger, he did S3 on me at Rob White's clinic.
Did he pull was he trying to go S to I, or was he just going P to A?
He had me on the high-low. I think he just went P to A. I don't think he was like trying to get any rotation. He might have done like a Pisces over thumb or something like that. But I think he checked my leg length, and it was like, it changed pre and post adjustment. just of the S3. So, I don't know.
Yeah, leg length will change on an L5 adjustment too.
Mm-hmm.
Everybody thinks that it's an ilium. You got to adjust the iliums to change, what you're trying to change with the leg length, and that's not the case.
I mean, upper cervical also uses leg length, and they see changes pre and post after adjusting an atlas.
Right. They think they do anyway. Can we see the A to P, please?
Anything specific or down here? Let's see.
Just lumbopelvic, yeah. Let's see how his positioning looks. Another patient that swallowed a zipper. Looks like he's pretty well positioned there, doesn't it?
Yeah. Mm-hmm. The zipper replaced the gluteal fold.
Yeah.
Unless my pants were on weird.
So now, if we think that he's positioned good, now if you look at the lesser trochanters and then the space between the lesser trochanters and the ischiums, now the difference there can be more trusted because we know that he's square on the bucky.
This looks pretty significant of a short leg on this left side, right?
Yeah, the measured deficiency, yeah.
I think it was 6 or 7 millimeters of MD, and when they did the measurement, I think it only changed it like 1. It went from like a 7 MD to a 6 AD.
On the left side.
On the left side, yeah.
Marcos, can you scan up just a little bit so we can see the top of the iliums? There, that's good. So look at the stress of the bone at that L6. Yeah, look at the stress there.
Is it like putting down new bone?
Yeah.
Okay.
I think that's because of the hyperlordosis there.
Like right at the facet?
Yeah. Yep, and even the sacral facet as well.
What about the other side?
A little bit on both. Yeah, the left looks worse. So do you think the body, or do you think the rotation of sacrum matches what L5 and L4 are doing?
I would say so. It looks like it's rotating on the left. This looks longer than here.
Okay.
Mm-hmm. And the L6 and 5 of PR.
Yeah.
Doc, doesn't it kind of look like this L6 looks like it's kind of part of the sacrum? Like not fused S1?
I think it looks that way because of the hyperlordosis.
Okay.
Because on the lateral, it doesn't look like that, but because of the hyperlordosis, it looks like that on the A to P.
Okay, thank you.
Yep. So, but we can't say L5 is PRI-M because it's not P.
Yeah. You wouldn't even list it.
How does it's almost like a rudimentary disc. How does that affect, like eventually will there be, will it rub out, just like wear out almost?
No, I don't think so because, there's people in their 60s walking around with sacral tubercles.
Okay.
I would just say to you, I wouldn't put a lot of weight on your shoulders doing a lot of deep squats. Right?
Okay, I'll pretend I didn't hear that.
You wear a belt?
No. So I stopped using a belt a long time ago because used to use it, but then I just kind of dropped all my weight and then built myself back up to have the musculature, like the core strength to hold the weight. So I don't use a belt for squats or deadlifts anymore.
Okay.
The natural intra-abdominal.
Yeah. Like it's I think the belt is like a crutch. A little bit.
So Brittany's the one that's taking care of you?
Yeah. At first it was Marcos, and he got too busy for me, and then he shipped me off to Brittany. But so Brittany's been my most consistent doctor so far.
So Brittany, what are you fixing?
The base posterior, which has like not been there as often because he comes once a week. So I would say I really do that now, like every couple of visits, not every time. And then it's a T3 sometimes, and then there's a lower one, was it T9 or T8?
You did 10
And he
the
has
first time.
yeah, he also has like an L2 that I found
Yeah, I'm not surprised.
that I've done without doing when I don't do the base posterior, I found that L2.
Do you see anything funny happening with his leg length?
I have not checked that.
Okay. Because again, look at the spinous rotation of everything above the sacrum.
All PR. Are they all PR?
Let's take a look. Can you go higher just to see?
Yeah, for the most part.
Yeah.
But then they kind of go a little bit left, but then they kind of go right again. Yeah.
This is the big PL.
Yeah.
So he's got quite a kink in there. Let's see, what vertebrae is that? 1, 2. Looks like 6 or 7 is where things take off. Is that 7 there?
This is 7 where my marker.
Yeah. So look at 6. Look at that big wedge on 6, and then it stacks from there. I don't know what the lateral looks like in there, but
So 6, 5, 4, 3, 2, 1, 12, 11, 10, 9, 8, 7, 6.
yeah, right in there. Yeah.
Okay, so when you're looking at the lateral and the thoracic, what exactly are you looking for? And what bone do you?
Couple things. We're looking at the apex of the curve. We're looking at the disc wedge. So the more kyphotic, then chances are you're going to find the disc wedge open in the back. The more less of a kyphosis, right, in the dorsals, then it could be more open in the front.
Would you consider this a hypophysis?
I consider a little hyper.
Hyper. Okay.
Hypotic?
Yeah, because the discs are open in the back.
Okay.
It'd probably be easier to tell if you turned it.
Oh, yeah. Like Dr. Martin showed a couple points ago.
Yeah, you could turn it. I don't know if you can do that, but that might be easier to see it.
Sorry, hold on. There you
He's
go.
on his head. There you go. Yeah, so zoom in there. So see how you just see that natural transition?
Yeah. What about that? This one. Does that look posterior and like close in the back?
Yeah, so is that T10?
I don't.
I think that's T9 because I think we were pointing at the apex was T7. Right?
11, 10. This is 9 right here.
Yeah, that's what we normally do. And then I think one time I found a T8, but normally it's T9.
Okay. So trying to find the most posterior.
Well, yeah. I wasn't looking at the X-ray when I found it. It was just where the break was.
Is the disc 7 and 8 open to the posterior like too much?
Well, that's where it starts.
Okay. And then the stacking starts.
And then between 8 and 7, it's really open in the back.
Yeah.
So if you look at, if I think it's right in the 6, it's got an open disc at the inferior end plate and an open disc at the superior end plate. The next one down.
This one's 6, so 7.
That one's 6. Okay, so then it'd be 7.
Yeah, that's open.
So you would do that based off like just this X-ray. You're thinking 7.
I wouldn't be afraid to adjust it.
Okay.
But if you're not finding a break there, don't fix it. How's his neck look? Putting all that weight on his shoulders, right? What's it doing to his neck?
Oh, sorry guys.
I think the sectional looks a little clearer. Do you have that one?
Yeah, he's needs to be adjusted much lower than his cervicals.
Yeah, Brittany's been doing T3, she said.
Yeah. You just get in trouble getting into his cervicals, I think. Maybe T1. Maybe.
It starts going posterior here, right? Starts.
Yeah.
Then it
That's 7. Yeah. You've been fixing T3, you said?
Yeah.
Okay. And is that helping?
There was one time that I was like, it was like really stuck, and pretty much the whole one side of my back was tight, like all the muscles. And then I think that was when Marcos was still adjusting me, and then he did T3 in the chair, like a PLS, and it relaxed everything.
Okay.
But Brittany's been doing it in the knee chest and the high low, and I think one of the knee chest adjustments, I think she sent it home for like a month or 2.
Yeah, his T3 doesn't need to be down nearly as often.
But when you fix it, it really helps, huh?
Yeah.
Okay.
I think she did it the Monday again.
Yeah.
But it might be because I've been like looking down a lot and stuff, so.
Good. Yeah. I mean, you guys are right on track.
And someone was telling me I had like compression. Was it compression fractures at like L1, L2? I think. Like something funky with those.
This? Are you talking about?
Yeah, I think so.
Yeah, it looks like that end plate is a little compressed. But that's not the one you'd fix, probably. You'd probably fix the one below it. Or even the one below that one.
3.
Or that. Or the base just here. He's going on the base.
You could make a case for several of those upper lumbars, so whatever it is you're going to find.
Alrighty. Thank you, Stephen, for sharing.
Thank you, Doctor.
All right.
You're welcome.
Michelle was promised. She was next.
Michelle, how you guys doing?
Hi, Michelle.
Hi, Dr. Mizel.
Good to hear your voice.
Likewise, you know. happy you enjoyed my voice.
All right, want to give us a history, Michelle?
History of back pain since 2017. I used to work in a warehouse for 2 years prior to that. So I think my back pain stems from that. I know around like COVID era, like when COVID first started, like around April of last year, like my back got like so locked up, like I couldn't barely walk, even bend down. It was pretty bad. I did go to clinic. Side posture was really hard for my intern, so that never really got resolved. What helped was like exercise, but it was still like that prickling, sharp pain in the back. My back pain was pretty consistent for like the last year. So I know like you guys worked on like a PIEX, am I right? And then I remember Dr. Vin worked on S3, if I'm not mistaken. And yeah.
Can you magnify that, please? So where's your pain, Michelle?
Right now it's like right like in the middle, like in the like very low, like in the middle, around like let me feel. Yeah, around like my PSIS area. It's in the middle. It's not lateral. It's more medial.
Well, there might be something to that S3 or the S2 tubercle, because you're pretty hyperlordotic, which is going to make the L5 look posterior.
You said S2, S3, or S1, S2?
They actually both look a little involved, but the lower one would be S3. How did you feel after he adjusted that, Michelle?
I feel actually pretty good.
Yeah. Did he do that push or high-low or?
If I'm not mistaken, side posterior.
Okay. Yeah. So I think based on your hyperlordosis, that's probably a good place to start and stay for a while.
Mhm.
Can you scroll up a little bit, Marcos? A little bit more? Yeah. So look on the lateral here, from starting at L3, see how it just all stacks straight up? Yeah, so you really don't need to fix anything up there. Sometimes you have to fix an upper lumbar to help hyperlordosis, but I don't think so for Michelle. I think you need to stay down on her sacrum.
Is the L4 a little posterior?
Yeah, I think that's just compensating for what's happening below it. Yeah. And it stays pretty localized, right, Michelle? It doesn't radiate or travel?
No, it's very localized.
Okay. And who's treating you right now?
Carlos.
Oh, okay. What's he been fixing?
I know we were gonna jump around, but right now, 'cause I just came.
It's mainly ilium and thoracic around T6.
T6.
Yeah.
So are you not seeing a reading on that tubercle, Carlos?
No.
Okay. Can we see the A to P then?
No problem. Luca, recoge la loncherita.
Can you magnify it just a little bit? And then raise it up?
Specific.
Yeah, if you could raise it up first. Oop, too far. Nope, the other way. There you go. Thank you. What does that say on the sacral rotation on the left? Does it say 57 or 67?
67.
67, okay. Well, that matches the rotation of the L5 then, doesn't it?
Mm-hmm.
So, Carlos, you're fixing the right ilium?
Actually, it was the left one. That day, she was moving on that left side.
So, you were fixing it, what listing?
That ASIN.
ASIN. How did that go?
I think it was good, right, Joe?
It was good, yeah.
Yeah, she liked it.
Okay. Because usually 85% of the time, if you're going to adjust an ilium, it would be on the side of the rotated L5 body rotation, right?
Mm-hmm.
So that's that doesn't fit our hyperlordosis, does it?
No.
But it may be chronic enough that, or here's the other thing too, Carlos. Scroll back up. So have you checked her leg length?
No, her.
Okay, so look what you see there. You see an ASIN on the left, and it's the same side as a posterior rotated sacrum. So you might have made her feel a little bit better by being on the ASIN, even though it's a hyperlordosis, because that is the correct SI joint to be on, but you might need to be on the sacrum instead of the ilium.
Mm-hmm.
And so the way you're going to be able to figure that out, possibly easier, is to do that prone leg check. And if it's shorter than expected, you'd adjust the sacrum, and then you could adjust the sacrum with the tubercle.
Mm-hmm.
So you could do a combination of a tubercle on the posterior rotated side of that sacrum.
Mm-hmm.
So I'd be curious to see what next time when you see her. When do you see her again?
Tomorrow, right? No. Yeah. I don't remember. Michelle, come on. Help me out.
Oh, sorry, I was muted.
No, keep it track.
Tomorrow 4:30.
All right. Tomorrow, what time?
4:30.
Oh, yeah. I remember now. Yeah, that's true.
So, Michelle, did you understand what I was talking about?
Yeah.
Okay. It's that SASIN listing that can be tricky. So you always want to suspect it when you see that happening, and then you want to check the prone leg check for that.
Doc, does the scoliosis of the lumbars kind of surprise you with the IN being on this side? And you think that would push it to be kind of concave on the left?
Well, I'm thinking the sacrum is rotating that side and it's jacking that side up.
Mm-hmm.
So she, if you go by the AD there, she shouldn't have much of a shortness there. And if it's shorter than expected, then we know it's the sacrum, not the ilium. My guess is going to be the sacrum along with with one of the tubercles there. Can we trust the positioning on that?
Pretty off to the right.
She looks pretty twisted, yeah. So definitely do that leg check.
I will, Doc. I will.
So visually, does that left ilium look like an ASIN when you look at her from behind?
Mm-hmm.
Yes.
Yep.
Okay. Good case.
Can you look at my other X-rays, please?
Yeah, the rest of your spine, yeah.
Yeah, because I also have like mid back pain and neck pain.
Okay, let's look at that. Do you have headaches?
Usually no, but I actually have one right now.
Do Do you have sinus problems?
No.
Can we see the lateral cervical?
Doc, why did you ask about the sinus problems? What did you see?
I guess I always, when I see Michelle, she's always sniffing her nose, so I'm thinking she's got allergies.
Okay, I didn't know if you saw something on the X-ray.
Stop. I'm not sniffing my nose, talking about. I'm just. It smells funky usually, like. Like the smell has a musty smell.
Maybe you got an ongoing head cold. Maybe, I don't know. Yeah, she's got lack of a cervical lordosis. Can you zoom in on that a little bit? Yeah, there's a kink at 6, and then go up a little bit more. I'm sorry, down a little more. It's hard to see there, but so what do you find on her in there, Carlos?
What was that again? Sorry, Doc.
What do you find on her up in that lower cervical upper?
I'm not touching neck yet on her.
Okay.
But Dr. Myers, people usually do a C5 PRS.
People, you mean like diversified people?
No, like everybody.
Not me.
Not you, because you haven't touched it, but.
Okay, and they've been on C5?
Yeah.
And what does that do for you?
Nothing.
Yeah, that's right.
But one more thing, I'm sorry. I remember Dr. Sud did do an AS occiput in Mount Horror.
Yeah, I was just about to ask about that because it looks like it's posterior.
Didn't he also say you had post-COVID syndrome and that's why you were sniffling so much?
I think that's the last time Dr. Myers seen me when I was sniffling, yeah.
This looks anterior.
I don't sniff no more.
Right, Doc? You can see the anterior superior, not posterior.
Yeah, look at the atlas. Look how
it's almost
tight it is on that occiput.
It's touching.
It looks fused even.
Yeah. Either that or she's got an elongated mastoid process.
Mm-hmm.
Have you ever been in any kind of car accidents, Michelle?
Absolutely not.
Absolutely not.
She's got the same car. That's her first one.
I'm not sure I understood that, but
that didn't make any sense. But her first car is the same one that she still has now.
yeah. So I don't think I'd be on her C5. I think that's a waste of time. Can I see her A to P cervical thoracic? Okay, go in just a little bit. So, do you have any consistent pattern with neck pain?
Me, yeah. My neck probably always hurts.
Can you be more specific than that?
Alright, so like around like that C5 area on the right, it's usually tender. Right now, I'm like probably like my atlas area is tender also. It's not like a sharp pain, more so like dull.
So when Carlos fixes your mid back, does that help your neck at all?
Yeah, good question.
Mid back, no.
So it doesn't change the neck?
No.
Okay. So I would say start scope it in there and see if it's maybe T1, C7.
Carlos, didn't we do the last visit?
It was like a T3.
Yeah. Oh yeah.
Yep.
So go back to that lateral again.
Which one? This one?
Yeah.
This one we can actually start to see. I think this is 7 or 6.
I think right there where your cursor is, right there, I think that's T1, isn't it?
I think so. Either T1 or 7.
Yeah, I'd scope that pretty close there and see if it's you need to be on T1 for her.
Okay, Doc.
But it doesn't look like this stacks here, but not this. These are stacked.
Yeah, that one. So that I'm thinking that T1 is where the kink starts.
Okay, let's see if we can see it on.
Even 7 looks posterior, but I think it might be T1.
Is this her VP, you'd say?
Looks like it.
So then if we go here. 1, 2, 3, 4, 5, 6, 7. But yeah, it's probably 1.
Yeah, right in there. Is she puffy up in there?
Yep.
Yeah, puffy and tender there.
Yep.
Yeah, that's where you got to go.
I was trying to stay low the first 2 first visits.
Yep, I get that. Yep, there's nothing wrong with that. Yep.
Okay.
But it's definitely not C5. No.
No. Not even. Dr. Miles, can you also do my thoracic? Because I've also told Carlos this, it's like more so, it feels like musculature, but I don't know what it is. It's around around T5 to T7 area, but we have been working on T6. But it's been consistent for the last year, no matter what I do. Actually, the only thing that has ever helped it was doing chest workouts. But then once it gets touched, it goes back to being painful.
Okay, can you scroll down a little bit for me, Marcos? Yeah. Can we look at that lower dorsal area just for a second?
Let me go on the thoracic lumbar.
Look at T12. Go down just a little bit to make sure I think I'm seeing what I'm seeing.
I think this is 12, right?
Yeah, that's what I was looking at. What does L1 look like below it?
Five, 4, 3, 2, 1. Here.
So what's that one?
That's 1 right here.
That's 1. 12 looks different there than it did in the other one.
Yeah. Maybe this is 12. Yeah, this one looks like 12.
That's what I was thinking was 12.
Yeah. It might be. It looks.
Is that one? The one I'm thinking I'm looking at?
Right here.
Yeah, that looks funny there. You might want to check that with your scope. That might be where the mid-back problem starts.
Like L1, Doc? T12.
L1, T12.
Found spot. Okay.
Yeah, see what you find in there. Especially since that T6 area is not holding for you.
Mm-hmm.
Am I understanding that right, Michelle?
Yeah, and it's super sharp too.
Yeah.
The pain is more lateral too. It's not on the spinous.
Like in the concept.
Hey Doc, I have a quick question. I don't know if this is a bad question, but I'm wondering why did they put a right mitral marker in there?
I don't know. She should, I don't know if it was her right shoulder up against the bucky. But then they don't have her turn.
They don't have the right lateral and then flip the image or something?
Well, it's not going to matter, but I don't know. I mean, you could turn the image the other way and then it might make more sense.
All right, just wondering.
Yeah, I don't. Is that was taken at Dr. White's?
Yes.
Okay.
I think he always leaves that R.
Oh, okay.
Because he turns his patient's left side on the bucky.
So you think he'd have the left marker there?
Yeah, he just left it there.
Okay. But you got a few things to check on, Michelle. I think you can. Nothing that you can't fix. Just look to see what that leg length is doing, and see if you can find that lower dorsal that might be a problem there, and then that T1 area.
Good stuff.
You're welcome.
Alrighty, we got Johnny.
Right, I just looked at my films. He does always leave that right mitral marker up there, actually.
I do with the mask around Michelle. She has sniffles.
All right, so we got Johnny.
We got a nickname, Michelle Sniffles. Is that what you said?
Yeah. She does always have a stuffy nose.
See, that might go away if you start fixing our first dorsal there, Carlos.
Yeah.
Get that thyroid working better.
All right, Johnny, let's hear what your give us a little your history.
All right, so like my lower back has been troubling me. I don't know if it's for about like 2 years. I don't know if because of football or lifting weights, but I think it's around my L5, and basically like when I stretch it out, it feels better, and like the pain doesn't like how should I say this? The pain it doesn't stop me from doing like every activity, but I feel it at like random times, or if I don't stretch before I lift weights or like run, then I feel a lot.
Those tubercles literally look like spinuses.
So, can we zero in on that sacrum a little bit better? Okay.
In that there.
We see it, but it looks kind of parallel to me. But, if certainly want to get in there and palpate it out, see if maybe the one below it more open than that one.
This one?
Maybe. His L5 is definitely posterior.
Yeah.
And he's got a hyperlordosis going on, doesn't he?
Oh yeah, that's the first thing I thought.
Where are you talking about? Where? Right there?
Well, the hyperlordosis we were talking about here, but then Doc also said S3.
All right.
Is there a side that your lower back pain is on?
No, it's like directly in the middle. And like it's something weird that happens, like when I do push-ups and stuff, like it cavitates. Or like if I like extend my stomach, I can like make it cavitate. Like I think it's like hypermobile or something. Or
so if you go into extension, you get a cavitation.
Like if I like stick out my stomach, I can like make it cavitate. Or if I'm doing a push-up.
Can you tell where it's coming from?
I think it's L5, but I'm not sure.
That could be compensation for what's lower in those tubercles, but can we see his A to P then?
He also has some feet x-rays too.
What kind of x-rays?
Foot x-rays.
Foot? Oh, okay. So I can't, is the gluteal fold going through the symphysis?
Yeah.
Okay.
Straight on.
So he's got a low femur head on the left, doesn't he?
Yeah.
And he's got a low sacrum on the left. And can you zoom in on L5? Looks like he's got coronal facets, doesn't it?
What does that mean?
Sorry. So this angle right here.
Yeah, there's some, his facets are kind of funky down there. That might be part of why he gets that clicking and extension. Can you back out just a little bit? That's good. Do we agree with that sacral rotation?
Doesn't make too much sense.
It doesn't, does it?
So, Doc, it looks like it's pretty square on the S2 tubercle, but maybe the left line is too much to the right. Are you thinking?
There's something that doesn't look right. Because L4 is PR. So L5 should be PR as well. And he's low on the left because of his femur head. The sacrum's low on the left. Would he fit the rules for a heel lift if that was maybe a possibility?
I mean, that's not enough of an AD, is it? It's only 5.
Well, it kind of depends on what you're trying to accomplish with him.
So it's on the side of body rotation.
Yeah.
And at least here, these two.
And the convexity, right?
Yeah.
Yeah.
How high up do you want to go, though? Because it looks like at L3 it starts to go on this side. Does it matter? Or
back out a little bit so I can see.
You see
I think you. Yeah, it's nah.
That wouldn't make too much of a difference.
So is that AD correct? Based on those numbers?
So
what is that? PI1, EX1? Is that what they're saying?
Yeah. So that'd be 2. 1, 4.
Looks like it. Yeah, it's not much changed. Okay. Because when you correct that ilium, you'd raise the femur head. Yeah, if you were going to put a lift in there, it'd probably be what's that measurement on that line above the left sacral groove? Did they measure that?
6.
I just don't believe it's that much. Do you? I think that's too much.
Yeah.
I don't think it's that much.
It looks a little high, maybe. Like it's.
And I don't like. Look where his right dot is. That's way off.
Yeah, it's supposed to be like right here, right?
Yeah. So I would, if you're going to put a lift with him and experiment with him, I wouldn't go more than 3 millimeters. I'm going to guess that if you measured that correctly and your lines correctly, it'd be more like 3 millimeters.
So what do you think this part right here? Like I see some ever so slightly, just a little bit of white, but it looks like it's definitely connecting here. Maybe they got distracted by this little whiteness.
Maybe. Yeah. That's probably the front of the sacral promontory.
Okay. That makes sense.
So, he's had chronic low back pain for 2 years. So, so maybe a small lift might be the answer to some of it. But if you're going to do that, you have to get the patient to commit to do it, to wear it and use it every day. You know, those lifts they're only cost about $2 a piece, especially when they're that little and you just put them in the shoe. And then what you could do is then take another X-ray and see if it changed things the way you wanted it to change it.
Well, I only have I have like a shoe insert in one shoe.
You have what?
Would I just have like an one shoe?
It's a lift. It's not an orthotic. What do your feet look like?
I have X-rays there. They're flat. They're pretty flat. And like I do have a problem with like a sprained ankle. Like I have to take for practice or a game.
Do you pronate a lot?
Probably. I don't really know, but probably.
Because if he pronates a lot, then I would be more concerned about that than I would the sacrum being low on that side. Because you might be able to fix some of that sacral problem with like a foot leveler's arch support.
But what do you think, like what can I do about my back? Like, why does it keep on, like, popping when I do push-up and stuff? Like, how
that's what we're talking about. So if you go back to the lateral, and then get up closer to those sacral segments.
Wait, this. That's funny.
There you go. Yeah, so that's where I would start with you. And if those are clear, if those sacral segments are clear, then I would be looking at your fifth lumbar.
Okay.
And then if that doesn't bring it around, then you might consider arch supports first. And then that might be the last thing, or you might have to do an arch support with a small lift as well.
All right.
What's been being adjusted on you?
I have Michelle and Megan. They do like the side posture. I think it's L5. The pull, I think it's called.
Okay. Do you know what listing they're doing?
I have no idea. But it does, like, it helps for like 30 minutes, and then I feel it again after that.
Yeah, okay, so when a patient tells you that, that's when you start thinking, okay, I'm just not on the right bone yet. I'm not, it's not holding. It may be it might be the right bone later if you fix some of those other minor problems around it. That makes sense?
Does that normally mean you're too high or too low if it's not holding? Or to be either?
Well, it could be too high, or just the fact that it's not the right bone.
Mm-hmm.
It's just not the right level.
Doug, what do you think about this? Would that mean anything?
Yeah, well, it could. I mean, it doesn't look good. It looks really anterior, doesn't it? But he's not giving us really any parasympathetic symptomatology yet, unless he's more for him to tell me.
I think that's the only problem I have, lower back pain.
No pain sitting?
Robin?
Like sitting?
I don't know. Actually, if I sit like a long time, like I'm not being like over dramatic, but I feel like pain like down my like leg, like a hamstring. But like I just like sit like that. If I sit a long time, it really happens.
Pain down which leg?
It's like down my hamstring.
Both or one?
I don't really know. I want to say like might be my right side. But if I feel it, then I just get up. I don't know if it's because of like I'm sitting too long or circulation. I don't know what's causing it.
Okay.
But I think it's fine. Like, it doesn't bother me that much. I just get up if that happens.
Yeah. But see, that lumbosacral angle is really really hyper.
Doc, what about, are these tubercles?
Yeah.
Just really big tubercles?
Yeah. You ought to be able to find those easy, right?
Yeah, that's what I said earlier. I was like, those things look like spinuses.
So, does it matter?
Unless that's somebody's hand on his rear end when they took the picture.
No, I don't think so.
So, Doc, does it matter that's only a PI1 EX1 for the hyperlordosis? Or it could be any, it's not really like the more PI-EX, the more lordosis, or is it normally like that? So that's why you're not looking like the ilium is the problem.
Yeah, I think it's more tubercle.
Just because of how small those numbers are for PI-EX?
Yeah, then go back to that A to P. And you know, if it's good positioning, like we think it is, yeah. And he's got those coronal facets.
So is there something you want to avoid when someone has coronal facets? Or you want to take in mind when you're adjusting as opposed to...
Yeah, so just be aware of it. So like if you're going to be doing torque and lift, you want to, whichever side your contact's on, you know, that might affect how you're going to do the lift and the torque.
Okay.
Especially if you have asymmetrical, where you have sagittal on one side and coronal on the other.
They look pretty even both sides, right?
Yeah.
Is that the same as a tropism?
Yeah.
Okay. Yeah, I have it on one side, but not the others. And my L5 always clicks too, so this makes a lot of sense.
Okay. Yeah.
So what do you do when it's like that and it's only on one side?
I just make, it depends on what the listing is on that side, how I'm going to deal with it. You know, if it's just body rotation and it's sagittal, or is it body rotation and coronal with an open wedge or a closed wedge?
Okay.
It's really, I'd have to show you, I guess, with a real person, with a film, and then talk you through the listing with the torque.
Yeah.
Whether it's more lift or, I mean, no matter what the facets look like, you still gotta adjust it according to the disc.
Did you want to see?
Yeah.
So this is his lateral.
Oh yeah, look at that. So do you see the top of the talus? Okay, now see how much higher that is than the top of the navicular bone, the next bone down? Okay, and see how the joint space is open at the top and it's narrow at the bottom? Why don't you magnify that a little bit? Yeah, see that? So what's going on? Is the talus superior or is the navicular inferior?
Say the talus is superior.
So are you going to fix the talus or the navicular?
Well, wouldn't it matter if he pronates, like if he has a drop?
Yeah, I think he pronates because his navicular bone has dropped down so much.
So you're saying if he didn't collapse his arch, you would think that is a talus problem, but since his arch is collapsing right here,
I think it's a talus or a navicular problem. Yeah, whenever you see the joint space open at the top and narrow at the bottom on the navicular bone, that's what you got to fix.
What about, what do you see on these? So this is just A to P, and then this is oblique.
Yeah, okay. Looks like he's got a bunion. So that's a two-part thing you have to fix. Now, if you magnify that in there, it doesn't look like he's got any arthritis showing up yet. So you should be able to work with that.
So part 1 is here.
What are those kind of bumps right there? Are those like osteophytes or something, or what are those?
Those are sesamoid bones.
Doc will text you on it. Don't worry. They're coming. And then this is the true subluxation you're saying right here, right?
Right, yeah, the base of the first metatarsal.
Does this joint space tell you anything, or not the same?
You probably can see that better on the oblique.
Actually, that's not too bad.
Yeah. But see how much it's rotated underneath? See the overlapping of the bone? See how much it's rotated underneath the second metatarsal?
Yeah.
Because remember, that's where you're gonna adjust it lateral to medial up there, aren't you? So it's showing you the rotation there. Now go back to the other film, the A to P. See how close that first metatarsal is to the second one?
Yeah. At the end, like the bottom?
At the proximal end or the base of the first metatarsal? Yeah.
Thank you, Johnny.
Does your other foot look like that too?
They both have bunion.
Yeah.
So,
and do you have pain in your feet anywhere?
no, I just sprain them a lot. I have to tape them when I used to tape them like before practice and stuff.
Sprain them which way?
It's like I don't know. It's like it will hurt at the top of it. It would just hurt like on the top here.
Can we see the calcaneus?
Do I have a lateral or?
Yeah, let's look at the lateral first. Okay, so let's look at the A to P now.
Oh. Is that the joint space you want? This one?
What I was trying to find, I was trying to see if I could see the rotation of the calcaneus, but I can't.
It looks
see it very well.
right? A little bit medial.
Yeah.
Or lateral.
So,
That's lateral. That's the fibula, right?
yeah, so whichever direction that calcaneus is going, we want to set it the other way underneath. More typically, they go medial, correct? They misalign medially.
Does he stand on like the outside portion?
Yeah, even if they're pronated, they go medial, or if they're pronators, they go lateral.
If they're prone, they go medial. And if they have flat feet, that's lateral, right?
That would make sense, yeah.
Yeah, pronation is lateral, and then if they're over supinated, then it's medial. Right?
Yeah. So is anybody adjusting your feet, Johnny?
No.
Okay. You might want to have that calcaneus set and your navicular set. That might even help your lower back.
All right. Like my feet, they don't bother me. They just like sprain a lot. Well, they used to sprain a lot.
Yeah, they don't have to hurt for them to be part of the picture for the lower back. I've had a lot of patients that came in with chronic low back and hip pain, and they've been to everybody in town, PT, other DCs, MDs, and nobody ever looks at the patient's feet. And you look at their feet and you put them, you just do kind of like what I would do that was really simple and easy would be, okay, listen, we want to find out how much your feet have to do with your lower back or hip pain. So instead of, before you spend $400 on orthotics, let's tape your arches. You keep this tape job on for 2 days. Now you come back in 2 days and then we'll talk and look at them. And boy, the high majority of the time they say, you know what, that really helped my hip and back pain. And what I'll tell them to do too is I'll say, okay, I just taped your arches. I want you to go to the grocery store and or go shopping or something. I want you to go out and walk for a while, because that's usually what they have trouble with, is prolonged standing and walking. And with those arches taped, and they come back and they say, oh man, I couldn't believe how much longer I could stand, and so forth. Then you know the feet are part of the problem.
So, Doug, what did you say about his calcaneus again? I'm sorry.
It just needs to be checked to see if it's medially or laterally rotated.
Okay.
So would you adjust my feet first or my ilium? Like what would be the first thing?
Well, you can do both, but if you've been working on the pelvis and the spine and things aren't changing, and you think you've given it enough of a try at it, then start looking at the feet.
All right, thanks. All right, thank you.
Yeah, a tape job is really simple. It's 3 straps of tape on each arch, and you send them off. Let me know how it goes. Yeah, let me know how it goes.
All right, thank you.
All right, Rachel, are you here? Rachel K here?
She's in the thing, yeah.
All right, does anyone, Macy or Kayla, when you guys want to go? Macy, Kayla, and Rachel, that are the ones that I have left there.
Rachel just put in the chat that she's going to turn her mic on so she can go next.
Oh, she just left.
I think she had to get a mic or something, probably. So hers are a little blurry at her cervical region when they took it. But
Oh, can you help me figure this bike thing out?
is it not working? We'll put someone else's on, but while you try and figure that out, okay? If you want to come over, you can use it too. All right. All right. All right, Kayla, do you want to go?
Sure.
Alrighty. You want to give a little rundown?
So, I essentially have mid lumbar pain, and then I have mid back pain as well. So for example, I'll bend over to reach into a drawer to get a t-shirt, and I'll have like super sharp pain in my lumbar area, and then just regularly I always have like mid back pain, but that's basically it.
All right, can we focus in on that lateral sacrum lumbar?
A little hard to see the picture of a picture. Is that all right? Can you see that?
Yeah. So when you say mid lumbar, do you mean like L5 midline, or do you mean like upper mid lumbar?
I've been having pain kind of around like L3, L2 area. It just kind of varies.
Okay. Can you scroll up there just a little bit?
So I guess upper lumbars, excuse me.
Oh yeah, okay. So yeah, look how posterior L2 is there. And look how the end plates are showing stress on L2 and L1.
It looks like it's all the way, right, Doc? Like there.
Yeah, but more so between 1 and 2.
Uh-huh.
Go back down to that sacrum though, because I thought I saw a sacral
like here
there. Next one down maybe. No, next one.
Okay.
That one.
Okay.
Was that S4 between 4 and 3?
Yeah. 1, 2. Yes, I would say so.
Yeah. So that lumbar gravity line is supposed to, if it has been drawn correctly, normal lordosis would be in the anterior third of the sacrum. So, but L5 looks really posterior inferior. So I'm wondering if that sacral tubercle, I haven't seen the A to P yet, but I wonder if that tubercle might be creating some of that. But yeah, for sure, her. We'll see what the A to P looks like, but that L2 looks really suspicious.
What about even here? You think that's like you think definitely causing the problem because of the IVF?
It's just so posterior inferior.
Yeah.
So let's see where the stacking is on the A to P. Yeah, it might be 3. 3 or 2.
Yeah, it looks like 5, 4, 3 are all straight, and then 2 goes right.
Yeah. What have you been having adjusted, Kayla?
I normally get, I think, Macy, what segment were we on last time for the lumbar? Do you remember?
L4.
It was
Yeah,
L4. Yeah, so L4, and then the last person to adjust me was Carlos. I think that was yesterday. I think he was on
He was on what?
So I yesterday I wasn't on the low back. I was just on the thoracics. But I remember going sacrum the last time before. That's not.
Yeah, and that got me a lot of relief too in my lumbar area because I couldn't even tolerate anybody like pressing on it at all. So he did that, which freed it up a lot.
So he did a sacral tubercle that helped?
Yeah.
Which one?
I just stay on this too.
S2. Okay.
I actually milk it. I mean, the sacral. I don't know. It kind of sounds weird, but it seems to help her.
Okay.
And the last time it just did a little thrusting, and it worked.
Can I see the full pelvis? Scroll down so I can see what that, and then magnify that a little bit. Thank you. So on that sacral tubercle, were you more on the right side of it?
Yep. My bicycle.
And you pushed it?
Yeah, just beat away, straight beat away.
Okay. Is L5 tender on her?
Oh yeah, that day she was super tender. I mean, super tender.
Have you ever adjusted her L5?
No.
If the sacrum's not clearing out, maybe you have to go to 5. But boy, that looks like that L2 is just begging to be pushed forward.
Kayla, what was Dr. Wood's segment? I mean, what Dr. Wood adjusted you before?
I think it was my L4 that he actually adjusted because I've been having problems with that. It's been super painful and just uncomfortable. So I think he did it in side posture and was able to get it go, and he did a pull.
Okay.
Yeah, I think that was 2. I'm not, because wasn't Mac trying to get through, and then he couldn't get it, and then Dr. Wood went for 2?
I don't remember. I want to say it was 4, but I could be completely wrong.
Yeah, I think we were kind of amazed that he was going to go even for side posture for how high it was.
Oh, yeah, like you wanted to pull the second lumbar?
I think he did a PLS, pull, involved side, left side up, and we were all kind of amazed. We were like, what are you doing? But
can you scroll up so I can see the lumbar?
Because I remember him trying to adjust me on the slot table, and it just was not going well. I don't relax at all. So it's very difficult to adjust.
So he adjusted her L2, you think, PL, and pulled it? Involved side down?
PLS involved side up. Left side up.
PLS involved side up. So, so do you understand the reason why he did that?
He said there was a reason. I don't know if she couldn't relax on that side or something made him want to do that. And that's just what he said he was going to do it that way. So the only way you can get away with that is if you know for sure that you're going to pull it as a finger push, just as if you were going to push it PLS. You're pulling it, but you're really good about that posterior E to A with your fingertips, and you're pushing it then left to right as well. Yeah, I think Dr. Wood's the only one that was really going to be able to do it that way.
Yeah.
That was great.
Well, Kayla, you'll be a good case to work through with trying to rely on the scope to tell us what to do based on what your lower back looks like on that film. Because you got a couple things going on that need to be kind of sorted through.
Okay, thank you.
Yeah, can we see the rest? Your torsos there? Can I see that lateral cervical again? My goodness, what did you do there? So her chin's down a little bit. Her chin is down a little bit, so that's a little distortion, but can you go in just a little closer? Yeah. Have you ever been in a car accident?
Yes.
Ah. Now you know why I asked that, right?
Because my neck looks bad.
A bit of whiplash.
So can you go down a little lower now?
I was T-boned when I was in high school.
Yeah, so look at the back. I think that's C6 there. Look how even C6, the disc space is open in the back. So have you ever had anybody adjust your neck up in there?
C7, yes, and then my Atlas.
And how did that go?
I felt a lot better.
You got away with C7, even the Atlas too?
Yeah, I've had really good response to that.
Yeah, that was the video I showed you.
Oh, okay, that's right. Okay. Yeah, that was a good adjustment.
It was cool, yeah.
It looked good.
It was cool. No, it was great.
But it was really specific and it was really isolated. He didn't twist your neck and involve any other segment.
It was a big clunk. I remember.
Yeah. All right, so let's look at that mid dorsal there then, because that's what's going to help her neck long term. Oh yeah, okay.
Yeah.
What are you thinking, like here, or even?
You'd have to back up a little bit for me to tell.
Like here.
Maybe the one below that. What's the one below that?
Let's see. You're on that one, so. 8. All right, so that one. So 5, 4, 3, 2, 1, 12, 11, 10, 9. This one, right here. This one.
Yeah, I think so.
So that's T9.
T9, yeah. Can you move up into it closer now? Nine or even 8. Look how rough those end plates are. And she's got Schmarl's nodes on that. What is that? 7 and 8. The end plates on. Yeah. Let's see what the ADP looks like in that area. T7, 8, 9.
One, 2, 3, 4, 5, 8, 9. Oh, it's the one that's outrageously hard to see.
It looks like, but see, look at the stacking change there. Is that where you've been, Carlos?
Last time, I think yesterday, that was one of them, and I was pretty low. I think it was T11 or T12 even.
Okay.
And she wasn't. She wasn't relaxing, so I have to trick her a couple of times, and I was able to get it finally, like after 3 tries.
Let's see what that T12 looks like on the lateral again.
I think it was T11 or T10 area. Yeah.
12 is right here.
Yeah, that based on how bad L2 looks, that might be too high. Not that you didn't get a finding there, but I think what's below that is what's holding that up.
Yeah, that L2.
Yeah. Yeah, good case. Good case.
Yeah, thank you, Kayla.
Dr. Miles, my two patients and Toll were Kayla and Kyle, so I'm kind of glad to see that they're actually tough and that it's not me. Maybe you want to stop Gonstead.
I'm sorry, I didn't hear all of that.
I said that my first 2 patients in Toll and quarter 6 were Kayla and Kyle.
Oh,
and
good.
I'm glad to see that it's not just me, but it's them.
All right, so this is Rachel.
Yeah. So there's a few different things going on, but back, I guess it's been 8 years ago now, I had 2 stress fractures through the left and right pedicles at L3. So I've kind of had back pain, lower back pain since then. But really my primary complaint right now is I've been having a lot of headaches recently, and this has been an ongoing thing the past few years. Headaches recently.
Headaches?
Yeah. Which the past few years I've had a lot of issues with like shortness of breath, different neurological symptoms, with like tingling in my arms, even my legs, face. I've had migraines with the aura. And I've had a lot of like anxiety symptoms too with that. I'm trying to think of what else. Yeah, where 2 years back. And we have found that when we do my Atlas, I get a lot of relief with my shortness of breath and the anxiety stuff. I just don't think it's holding that well. So we've kind of been going back and forth between doing an ASLP on my Atlas and then on my T2.
So can you say that again, Rachel?
Yeah, so we've been kind of bouncing back and forth between attacking the Atlas and doing an ASLP, which I do get really good. With that, it's not holding. So then we've been kind of going back and forth with that, and then T2. And it's a PRI, I believe, that we've been doing.
Can we see the lower back on the lateral? Can you get a little closer on the sacrum?
I will say I had low back pain for like 8 years, couldn't even go really into extension. And then I had Dr. Waller did my coccyx in Mount Horeb, and I haven't had as much relief in 8 years.
I remember you talking about that. Can we see the coccyx better? And can you take away the letters?
How's that?
Can you back out just a little? There you go. So did he find that on palpation or a scope or just looked at your film?
It's kind of a long story, but he originally, the way I guess my back visually was looking, and then he kind of went into further like with my neurological symptoms and stuff. So originally that's what caught his eye, and then when he palpated it, it actually like brought out a lot of my neurological symptoms that I've been having issues with the past few years. So he was like, yeah, we're thinking coccyx, because I asked him, he didn't even really look at my x-ray. And he said that he was just kind of chasing more the visualization and palpation on that finding than anything with the x-ray.
And is this an artifact?
It's my ID. Right there.
Oh,
that,
okay.
Yeah.
Okay, then just slowly go up the sacrum for me. Okay, stop.
Are you looking at a tubercle here?
Yeah, I was looking at that one. And then for sure, yeah, between, let's see. Yeah, I think those are the two, that the coccyx and then that S3 tubercle.
Doc, what do you see on the coccyx that is catching your eye?
You have to go down a little lower and get a little closer. Yeah, so if you put your arrow right, too high. Right there's the space. Yeah, right there.
Okay, and how it's tucked.
See how that's anterior?
Wow.
Yeah.
I didn't even see that.
A millimeter.
Well, it's down there. A millimeter is a big deal.
Yeah.
And Rachel, did you fall on your rear end?
I definitely had like one bad sledding accident when I was younger, but then I played volleyball my whole life, so I fell on it a lot.
Yeah.
Yeah.
Yeah, that's that might be something that needs to just be checked the rest of your life, just to make sure it's not part of what's going on. But then, when that becomes asymptomatic, when you can't find that anymore, then I'd be looking at the sacral tubercle. Because if you look at your L5 disc, can you go up to her L5 disc? That's pretty nice, right?
I think we've also done L3 a few times.
Yeah.
Forgot.
But she's given us parasympathetic symptomatology.
Yeah. So, what do you think about the neck region here? Because obviously the Atlas is giving her some good relief, and it's it's pretty. It's very superior compared to her on her left side where it's tucked under the mastoid. Compared to the right side, it's not. So, and if even you look on the A to P here, it's definitely pretty swollen, this capsule, when we did the measurements. So, but her T2 is what also shows up at times, probably from this straight presentation, right?
Can I see the neck with the hard palate?
Yes.
Okay, there you go. And then come in a little closer.
Yeah, whoever took this, someone took this picture pretty blurry.
It's the patient's fault. The patient moved.
I wouldn't be surprised.
Yeah, so look how open the discs are on all those, right?
Oh yeah.
So whatever you're gonna do upper cervical isn't gonna hold.
Mm-hmm.
Yeah.
Yeah, we normally go for this when she's having a pretty, like a flare up, and it really calms it down.
Yeah.
But if she's not, we're staying down in this area.
Yeah.
T2, T1. And if the lateral is pretty interesting too, I mean the A to P, because she's pretty straight here at 5'4", and then all of a sudden she goes for a pretty
Wild ride.
yeah.
So what is that? T11, T12?
It was even at 5, 4. I guess 2 is very wedged, but I thought it even slightly started here at 3, just ever so slightly. But then this one had a lot of wedging, and it kept going there, and then to the right.
Let's look at her T12 on the lateral.
Oh, I labeled it.
Yeah, see, that looks posterior to me.
Because of that hourglassing, kind of?
Yeah, and the disc looks just, your 2 is covering up the front of the disc, but...
Yeah, sorry.
Can you go back down to the lower back again on that lateral? Yeah. See, I don't see much of a break in George's line there if you want to, like, use that.
Mm-hmm. Yeah, they all seem pretty good.
Yeah.
Maybe.
I mean, I can see why you were talking about L3 a little bit, yeah. But what's causing that T12 to stack so bad on the A to P?
Yeah. It's very interesting. Because, I mean, L5 is nearly level. And L4.
Yeah, the sacrum is level. Can we see what her femur heads look like? So, what does her leg length look like prone?
I don't remember. What did we did for the tubercle that one time? But she has a 5 MD and a 5 AD on the left. Oh, I had that right here actually.
So does it look like that when you do a prone leg check? AD of 5?
Yes. Yeah, she has it. Yeah.
Okay.
Does it look that drastic of a 5 millimeter difference, do you think? When I was looking at it before, I didn't think it was going to be this much.
Yeah, I think so. And the sacrum is being affected a little bit. It's a little low on the left, a little bit,
Mm-hmm.
but not enough that you're going to do anything about it. You're not going to do a lift or anything.
Yeah. So what do you think is causing this whole scoliotic curve here then?
I think I would look really close at that T12.
T12. Okay. Because of how it's kind of kinked here and then going off.
Yep.
Okay. Yeah, those are all stacked.
Then look at it. It compensates at, what is that, T5, T6?
Yeah, this is 5 right here.
So what, do you find anything in there?
Yeah, I do, and I can kind of tell too with, I mean, I get a lot of pain right there, and kind of with my breathing, I feel really restricted.
Well, that rib on the left looks high. A little bit.
Well, it's attached to the vertebrae, so with all that rotation.
Yeah, I mean, I definitely do get it adjusted occasionally. I would say that it hasn't been a huge issue lately. It's mainly my atlas that's been a
And see, that one right there might be, between that one and T12 might be where you need to go to help your curve in your neck.
Mm-hmm. Yeah, because then after here, that's another straight line.
Yeah, everything's, yeah.
And then the atlas is so raised on the left because of that, right?
Yeah, that's compensation.
Yeah. Okay. I can see that.
So you're adjusting your atlas ASLP, you said?
Yeah. When she gets symptomatic, that's normally what we.
Yeah.
That'll calm it down pretty instantly.
So you know what you could do? You could experiment. So the next time she's having that kind of symptomatology, see if you can make a case for that the thoracic, even though we're considering that it's sympathetic, right? But what is an ASLP? That's sympathetic, right? So see if you get any change with her symptoms by being down in that dorsal instead.
Okay.
See if she gets the same relief reaction, or if if it doesn't change it, that tells you something. If it makes it worse, that tells you something. Because if you could leave that upper neck alone, that would be best case scenario, I think, based on what her curve looks like.
Yeah.
So we do the 12 and that 4 if I'm.
Yeah, I think you could do T12 and T5-6, whichever one it comes out to.
Sorry,
yeah. How does it look on the left? Or do you notice anything on the lateral that's telling you?
I'm just trying to see if I can figure out which one is which.
So this is 6, I think. I think when I did these, they all went to the bottom of the vertebrae when it got zoomed in. So this is 6 right here. So this one looks pretty wedged in the back, right? So then the one above the wedge in the back would be the one that you want to do.
Yeah, so can you turn that so it's the prone position?
Oh, hold on. Here we are. So this is 6.
Yeah, it might be. It's going to be 6 or 7.
7.
And those two would be, if it's 6 or 7, that would be far enough apart between the two that you could adjust them.
Yeah, that'd be interesting to see.
Well, thank you, Dr. Meisel.
You're welcome, Rachel. Good case.
Thanks.
Yeah, and it was cool because yesterday when Dr. Fowler had to talk about cranial nerves and TMJ, he was talking about how a very anterior second cervical directly affects the vagus nerve, and that can cause literally all the symptoms that she said, like sleep apnea, anxiety, breathing issues, from an anterior and wedged in the back C2.
Right, so, the compensation creating its own symptomatology.
Yeah, so that's why he said the symptomatology is saying up here, and you might get some relief, but being down here is going to be your best bet for sure. So so probably still too high with T2.
Maybe, yeah. But based on the A to P, I would say yeah.
Yeah. Okay. Well, thank you, Doc.
You're welcome.
Well, it's 9:14. I know we didn't get through everyone's case, but we don't want to take too much more of your night, Dr. Meisel.
I think I'm getting the hook.
Yeah, no, I understand. Trust me.
Yeah, this is fun for me. This is what, we should be doing in Pitt, where if everybody doesn't mind showing their films, where we just talk about each other's problems and then scope and palpate, and then that's when we'd want to watch you adjust each other and really, fine tune the whole process of your patient care. So, I guess that's what I would say that you would have to look forward to, would be us kind of going with that kind of format. Because as long as we have somewhere we can send you to get full spine films, and then we can put them up on the TV, that would be awesome.
Yeah, we might need to ask Dr. White if we can come one more time, because this was in May, I think, right?
Yeah.
Yeah. Well, thank you again for all of this, Doc. This was amazing.
Hey, you're welcome. I hope everybody found it helpful.
Super helpful.
Yeah, because we don't always get to, we normally give you cases about other people that aren't here, but when we're able to have the patient pretty much here and describing things, it's super helpful.
Yeah, it makes a difference when you hear the whole picture, doesn't it?
Yeah, and that's why it's another aspect to the system, not just looking at x-ray or not just palpating. It's everything.
Yeah.
But thank you, Doc. We appreciate it so much.
All right, guys. You have a good rest of your week.
You too.
Thanks, Dr. Meisel.
Thanks, Dr. Meisel.
Good night.
All right, good night, everyone.